So I appreciated Dr. Schwindner's question about the would anybody categorically not operate on a 90-year-old? I was the one person raising my hand. Not in a million years. I'll stick with the kids. So yeah, so hopefully some of this will dovetail in with what Dr. Legron was just talking about and what Matt Hollenbeck is going to share with us in just a little while as well. We're going to talk about the goals and indications of adolescent idiopathic scoliosis and its surgery. So we really need to dive deep into why the indications are what they are, the principles underlying what we do, and the data that can support or not support that. So just to draw a distinction, juvenile idiopathic scoliosis has a very clearly defined morbidity and mortality, and it all has to do with the development of the thoracic cage and the height of the thoracic cage and the number of alveoli and total lung volume. So there is a morbidity and a mortality associated with juvenile onset idiopathic scoliosis, but not necessarily with adolescent idiopathic scoliosis. And so there's been a thought in the world of adolescent idiopathic scoliosis that just because you're not going to die from this, do we really need to treat it at all? So we'll look at what data we have concerning the natural history of scoliosis, a lot of which comes from data from Iowa, which is where I did my medical school and residency. And hopefully we can shed some light on why maybe it's accurate and why it maybe isn't so accurate. So adolescent idiopathic scoliosis, it's not going to kill you most likely, but is it going to cause significant morbidity in the sense of pain? So in multiple studies over many decades, originally, the 20 to 36-year follow-up at Iowa stated that there was really no correlation between curve size and pain. Near the 40-year mark, the lumbar curves and thoracolumbar curves did show increased pain, and at the 50-year mark, there was a marked difference between the scoliosis patients and the controls in terms of pain. And yet, when you look at the interpretations or conclusions from that particular study, it will tell you that they didn't believe that difference was very significant. When we look at other studies with even shorter follow-up, I think you would find that there actually is a pretty good distinction between control groups and people with scoliosis in terms of back pain. I think it does affect them. When you look at my patient population, which is still entirely teenagers at the most, I would say the prevalence of back pain is quite significant, even in small curves, although it's pretty unpredictable. For example, this is a young lady who came into my clinic after having never visited a physician before. She was pursuing chiropractic care for this curve. She had absolutely zero back pain. Here's another young lady came in. She had developed a curve up to about 42 degrees here, had what she described as disabling back pain, particularly on the right side in the area of the scapulothoracic joint. So I don't think we can glean from the studies who is going to have pain. Here's another example, two relatively similar curves differing a little bit in Cobb angle, but overall similar patterns. And I would love for anybody here to guess which one had significant back pain and which one didn't. Right? It's very difficult to predict. Nonetheless, I think there is a correlation between the two, and I think we should not use the Iowa data to discount the fact that these patients can have significant pain. So curve progression, this one is a little more easy to define, but I think it's also relatively misinterpreted. So at 40-year follow-up in the Iowa data, curves less than 30 degrees pretty much stayed put. Lumbar curves greater than 30, they continued to progress at the rate of about half or a little less than half a degree per year. Thoracic curves were the most progressive, and anything between 45 and 55 progressed 30 degrees in the thoracic spine and 20 in the lumbar. Other studies have shown actually very similar data, around 0.4 to 0.5 degrees per year in terms of progression. Overall health, again, this is interesting data to try to interpret. A lot of these patients were from relatively rural places, even for Iowa. And so with large curves, we really didn't see much in terms of pulmonary compromise, certainly nothing that we would call life-threatening. When we looked at cosmetics, now asking a rural Iowa female how she feels about her body image is kind of like asking an Eskimo how he feels about his flip-flops. There's no there's no correlation there. It's really hard for them to answer that question. But even among the Iowa patients, they were relatively dissatisfied with their body image. Depression, they found similar to controls. Other studies, I'm not sure exactly how they defined real psychological disturbances in the Ascani study, but they found a correlation between the size of the curve and more psychological turmoil. So again, back to this young lady. How am I supposed to counsel this patient? And this is what I love about this particular conference, because we have so many of you who deal with the adult population. But here we have a 15-year-old female, 42-degree thoracic curve, significant rib prominence. She's now a RISR 4, 2-year status post-menarche, and she hasn't grown in 6 months. She has chronic right scapulothoracic pain for the last 3 years, no improvement with 3 years of physical therapy, physical medicine and rehabilitation specialists, injections. She's quit the swim team because she just can't take the pain anymore. She hates her truncal shift, and both she and her parents want surgery. So my traditional indications for surgery in adolescent idiopathic scoliosis would be a curve of greater than 50 degrees. And again, that's mainly based on the Iowa data, and that's just a Cobb angle. It doesn't correlate to much in the real world. So if this were a patient that we were trying to project 40 years into the future, how would we counsel her? What would we say? Will surgery save her pain in the future? Will it stop curve progression? Will it do all of those things and have acceptable morbidity? So looking at long-term outcomes with treatment, posterior spinal fusion. Imaging, I think overall we would say that the coronal plane, if we do a relatively good surgery, is going to stay pretty stable. If we look at the sagittal plane, even early sagittal plane malalignment is going to lead to early failures and poor outcomes. Lowest instrumented vertebra, Dr. Legrone referred to this as well. Going to L5 is almost categorically going to lead to poorer outcomes. With Harrington rods, even going to L4 led to poorer outcomes. And if you have a combination of those two, things can go very poorly. Reoperation rates are relatively stable across studies, somewhere in the 4 to 6% range. Pain is a little bit more difficult to get a handle on, but I would say that the rates of pain are relatively low compared to the rates that we see in the non-operative cohorts out of Iowa, Texas, Scottish Rite, and other places. So what have we learned from spinal fusion? I think we've learned sagittal malalignment is the kiss of death that has to be avoided at all costs. Lowest instrumented vertebra is an important consideration, and we have to find this balance between sparing levels and yet doing comprehensive enough surgery to achieve the alignment that's going to be durable. So again, I can't even tell you, in residency they teach me about, we've got Dr. Weinstein there and Dr. Ponsetti, who was still alive at the time. Jaren, when they get to RISR 4 and they're between 40 and 50, we have no idea what's going to happen. And yet, I would argue that we kind of do. I would say the studies actually do tell us that they do go on to develop pain, they do go on to curve progression. So, in AIS versus posterior spinal fusion, what can we tell these patients who are above 40 degrees at about a RISR 4? Pain, you're probably going to have some pretty significant pain, but it's not going to be disabling if we leave you alone. If we do a spinal fusion, you'll have pain. Again, it won't be disabling. Adjacent segments, as time goes by, will show radiographic changes, but we don't know how that's going to correlate with pain in the real world. Deformity, in AIS, your deformity is going to worsen. It's going to worsen about 0.5 degree per year. If you get a spinal fusion and we do the surgery well, it's probably going to be maintained and durable. Overall health, physiologically, you're not going to die from AIS. Surgery, you could. All right, so there's a big discrepancy there. Psychologically, you may have some psychological stressors because of your scoliosis, but it most likely won't be the determining factor in whether you're depressed or have major mental health issues. So this is where most of us get stuck, right? We're trying to find what's the best thing for this patient, and what it really comes down to is we really would rather not be the one to be blamed for the future pain, deformity, or any other complications that could occur. So what we need to do, the goals of treating these kids should be minimize the deformity, preserve their abilities, reduce pain. Interventions should introduce the least morbidity possible and maximize non-operative treatment. So bracing, I prescribe almost 400 new braces a year for patients who have never been in braces. We've got great evidence that bracing can work and it should be used. For those who fail bracing, casting I think is actually a wonderful option. This is a lovely young patient of mine who's currently undergoing bracing, and she loves to show off what she can do in that brace, and that is the least of what she does in that brace. And so sometimes it makes me nervous when she sends me those videos, but it's also really fun. None of us wants to harm a patient, right? We want to do what's absolutely safe and keep them on the right side of everything going well. Spinal fusion, I think, introduces a lot of potential for harm. Adjacent segment degeneration, whether that's symptomatic or not, adding on of the deformity, pseudarthrosis infection, your typical list. So this is not a case of mine, but I certainly have cases that can look like this. And I absolutely have hundreds of cases that look like this, where I wonder how much morbidity is a result of my fusion and not just the surgery. Meaning, is surgery really the bad guy here, or is it the fact that we're doing a fusion? So in the patient with the fusion there, I go home after a case like that and I wonder how much good have I really done for that patient, leaving that amount of lumbar malalignment. And on the patient on the right, I think, how much fusion do I need to do for this poor patient? They're just on the border of everything I can think of for a selective thoracic fusion, and I would be very nervous about leaving that lumbar spine alone. So how much is going to be acceptable? I don't think we have great answers for those. And sagittal malalignment, I think it's very clear that's unacceptable. So here's what we need to look at more often, I think. Not exactly vertebral body tethering itself, but the idea of guided growth and the idea of a fusionless way to restore alignment for these younger people. The latest or the newest studies are coming out. They're very short-term follow-up, 2 years. One from Dr. Samdani out at the Shriners in Philadelphia and one from Dr. Newton. They both have very low numbers of patients, 11 and 17. And they have significantly different outcomes. Dr. Samdani had very few complications, very few reoperations, and wonderful restoration of alignment. Dr. Newton had a 41% revision rate, which in my book would be unacceptably high, and this would be due to tether breakage, overcorrection, and curve progression leading to spinal fusion, which is exemplified by the pictures that you see at the bottom there. So looking at indications for surgery, this is the young woman that you saw just a second ago, 13 years old, Risser 3. She's been doing clear method chiropractic care, Schroth method physical therapy. Her curve has gotten very large. This is the first time she's meeting me. Lumbar curve does bend down to about 30, and she has a very large rotational component at both curves. So unfortunately for this young lady, indications in my clinic would be that we do both a fusion of the thoracic and the lumbar curve. And that is a very long surgery with risk of comorbidities, and that's something that needs to be counseled with the family extensively, but I think she'll be better off with it. So indications for posterior spinal fusion still for me tends to be a Cobb angle of 50 degrees, Risser 1 or older, more mature. Thoracoscopic anterior releases I've pretty much abandoned. Even in the very large thoracic curves, I just have not found it to increase my ability to create alignment. Growing rods I never use in adolescent idiopathic scoliosis. I'll use any other method to delay spinal fusion that's possible. Vertebral body tethering, my indications are still in development for that, but most likely it looks like it's settling into a patient who's around a Risser 0 to 2, curves between 45 and 65 degrees. And then there's always that thought in the back of my mind, is there a Cobb angle pain combination that's less than 50 degrees, but there's a certain amount of pain, and I can reliably tell that patient that a surgery would improve their alignment and their pain. I don't know what those magic numbers are, but we're in pursuit of that. So bottom line, if the goal is to be better than the natural history, spinal fusion is the best we have at this point for adolescent idiopathic scoliosis, but I think it has unacceptable future considerations, and I think we need to find safer, more durable, and motion-sparing solutions. And paradoxically, I think this may actually in the future end up expanding our surgical indications for adolescent idiopathic scoliosis rather than contracting them. Thank you.